Alright, we've got the heparin pediatric scenario here. So we've got Pat Smith, who's a 16-year-old male. He's been diagnosed with acute pulmonary emboli, and he weighs 110 pounds, which we'll use for determining our amounts given. The physician's order is heparin 75 units per kilogram as a loading dose, and a heparin drip at 20 units per kilogram per hour, and then titrating per protocol. We did double check, and with the pediatric doses, that is within the range. So the loading dose, once figured out with his weight, is going to be 0.75 mils, and the drip is going to be going at 2 mils an hour. Right now what we have pre-packaged is a 1 mil syringe with a concentration of 5,000 units per mil. So with that we're going to be giving 0.75 of it. And then the pre-packaged 500 milliliter bag of the D5W. That's this one here, that is going to be going. Right now we've got the D5W up, that's administering at 25 mils an hour. We did look in our book and it said it was compatible depending on the range and the dosage. So we contacted pharmacy and double checked and they said everything was good. So what we're going to do here is I'm going to leave this running since we're compatible. The bolus that we're going to give, we'll do that first. Wash my hands first, put my gloves on. If I haven't met my patient yet for some reason, I would make sure to introduce myself, but most likely they'd know me by this point. Make sure that he understands, especially since he's young, what we're giving him, why we're giving it to him, so that he's not freaked out at all by it. And also explain to him that we're giving it through IV, so we're not having to poke him anymore, because by this point he's probably been poked and prodded. So we're going to double check the right patient by the name and date of birth on the band. I'm going to verify with him as well. We'll have the right route, the right dose, the right amount and everything, and to make sure we're doing it over the right time. This needs to go over at least a minute. So first thing I'm going to do here is waste enough of it so that I only have 0.75 left. I don't want to give him the whole thing. Okay. Put the cap back on to keep sterility. So I'm going to grab my clave at the Y site, and we're going to administer it there. So since we have the D5W running, I won't need a flush before or after, because that's acting as my flush right now. So put this in, and then we'll just make sure that we administer it slowly over a minute. You can dilute it if you want to. It doesn't have to be, but it can be. So if someone wanted to have a bigger amount to push over that time frame, they could definitely do that. I kind of thought this was appropriate, so it didn't seem too bad. So we'll say this has been a minute. So we are done with that. So now he's got his loading dose. So now we need to set up the drip. Because we've got another primary line, we'll pretend maybe this machine can't do concurrent. So I would go and get a second machine. So with that, looks like everything's already primed. And this would normally have a cap on the end to keep it sterile. So we'll just say that, so this is my second pump. So this end is going to get put in there. Like I said, the cap would be on it, so it would be sterile. I'll clean off the Y side again here, and we'll connect it in there. So essentially we've got two primary lines running into one IV. So we've got this. The heparin pump that we have going would be set at 2 mils an hour, which is the other reason we need the D5W. We need to keep the line patent, and 2 mils an hour won't do that. So at this point we're going to monitor the patient, keep an eye on him, like I said, titrate per protocol as it comes. The other thing we want to make sure we have is the protamine sulfate, which is the antidote if there should be an overdose or issues with the heparin and we want to reverse the effects of it. The effects with that, we're looking for any kind of signs of bleeding, as far as hemorrhaging or bruising or blood in stools or urine, things like that. So we make sure and let the patient know, if anything like that happens, to make sure and let us know if we don't notice it first. So at that point, since we've got both of them running, we should be good to go.